welcome to the few. We are a group of graduate nursing students here to discuss two nursing theorists, Hildegard Peplau and Abdullah. So, although these nursing theories were developed in the 1950s, we believe that their work is still relevant to today in our nursing practice as we shape the next generation coming in. One key point of our discussion is going to be talking about how these nursing theories can be integrated or updated, so to speak, with the advent of quality and safety education for nurses, also known as QSEN. QSEN was developed from a group of academics funded by a Robert Wood Johnson grant that paid particular attention to nursing practice and safety. So as we shape the next generation of nurses coming along, we'd like to show how our founding mothers in nursing that developed are the basis of our nursing practice can still actually apply.
And is it relevant really? Is the QSEN relevant for now? Because that's our push in 2005. And these series, as you mentioned, they were developed some time ago. So we want to make sure that they're relevant. We have to still integrate them, because
they need to be tested.
Right. And their theories they were all born out of their experience. And we can't beat experience. We really can't beat experience.
When you talk about safety is very, very important, like we all know. It's the number one thing we all want to, it's one of the most important things we all want when we go to the hospital, or even when we're in our own houses, even the country, security is very, very important. So for this safety, the most important thing also is when the individual, like the patients and the providers, we as the providers too, we also have to be safe while taking care of our patient. When you don't know your patient and the patient doesn't know you well, there's bound to be mistakes, and then we cannot afford to, we cannot afford. There's no room for any mistake, right? Especially with this the new healthcare reform, where patients can go to wherever they want to. It's very important to know our patients very well. We also minimize the risk of infections, which is very, very safe. Many hospitals are implementing it. If you don't do something about it, of course, our patients can go somewhere else.
Our patients have more options today than ever. They're more informed. Gone are the days when the physician was God. Patients never questioned. If the doctor said do this, you did it. And they didn't ask why or how come. But now, in our current world, the internet is such a tool that patients are coming to their visits more prepared and more informed and asking questions than ever before.
And that's so true. That was very critical for them, because in those days, what was happening is that the patients would be going to the operating room, and they're cutting off the wrong limb.
Yeah,
exactly. And that's a big thing. You go in and you're supposed to cut off the right, and you end up cutting off the left, and then you're giving the patient the wrong medication. Those are some of the things that they saw that was happening in their time, and so that's why they're pushing the QSEN.
And then when you talk about things going on now, like evidence-based practice, we can all see what is going on in the country. Not only here, internationally.
Yeah, because I know with evidence-based practice, we have to integrate best with what they will do experiments or about the theories in regards to being on the floor.
Exactly, and we see what is happening in other hospitals. You see, most of us work in different places. Exactly. You go here, you see nurses who are into education research, like we're doing. They carry out researches. We have things that we have to work on, evidence-based. when something is carried out on a patient, we now see the results. After we identify the problem, you plan on it and then you implement it. Then on the evaluation, on the outcome, we now know if it was successful or not successful. On our evaluation, we now know whether we have to bring it out there so other hospitals can know what is happening.
Right, and so that's transparent practice and reporting. So we're not only sharing within our own hospitals or organizations what root cause analysis committees do. They look at a sentinel event and they want to understand why did this happen and how do we prevent it happening again. And now with our world of informatics that we have, we can share that beyond our own immediate communities and look and compare national data and global, look at international data so that we can, as a whole, improve care across a much broader spectrum.
I like this technology going on now. Just like you said, informatics. You can see things. It just takes but a minute for you to know what is happening somewhere else. You need the patient's information. You go to informatics. It's just right there. Electronic health record. There's this continuity of care with informatics. Which before, you know how long it takes to go to medical record. You have to request for the chart anyway. And then there might be short staff downstairs in the medical record. By the time the chart comes, this prolongs the patient waiting time when you talk about clinics, primary focus, which is what we're doing now. But with this primary care, you just go into the computer and then you get all the information about the patient. So informatics is very important.
And sometimes some of the documents are lost, or maybe the place that you cannot reach as fast as you need them. So that's why it's very, very important to use all these technology and
Having information at your fingertips.
Exactly.
Well, doing
Expedite
information and informatics is important. I have a concern. Yes, it's important and it's pushing very well and it's improving healthcare and we're having information at our fingertips. But it's kind of taking away from what these series really wanted. Patient-centered care, the touch, the feel. Because most of our times, and if we can recall, we sit before the computers charting. Yes, we're now able to read the doctors and writing, because seriously, no.
How many bed hours
I'm
have
wondering,
you
I'm
seen?
asking.
Peplau, the focus of Peplau's theory is very much focused on patient relationship and patient-centered care.
Yes.
And to bring that up from the 1950s to current time, the coin the phrase shared decision making is more our current word for that same philosophy to integrate her philosophy to current practice.
So there must be a balance. We can't just go for informatics. I am in for informatics. I mean, we're here. We're at Charles Drew. We're talking about the theories and we're using technology. And we use technology in class, and I'm sure all my fellow classmates they are on their iPod, they're using computers, right? But we should not take away from what's important in nursing. Care is really important.
We need to pick our head up from the computer and look at our patient in the eye.
That's it. Because many
How
times
much of their unspoken body language is part of the communication between the patient and the provider?
That's like
her theory breaks down the nurse-patient relationship into 4 phases. The orientation phase. I have to fill in the blanks here. What are the 4? Identification,
exploitation, and the resolution phase.
Okay. So with Peplau's 4 phases, it really requires the nurse to establish that patient relationship and walk them through the process, through the continuum of their episode or their immediate problem or hospitalization or whatever event they're having. So the patient relationship is important to get established and then identify and agree with the patient. So that brings in the patient-centered piece. So it
Identification
incorporates,
phase.
the identification phase. You're going to have the conversation with the patient and say, what are our goals here? What do you want to achieve? And then in the third phase,
Which is your working phase, actually. Yeah. That's when you start working
you're
with the patient.
implementing
Right.
the
Seeing
plan.
how you're gonna meet that patient's need.
Look at
Yeah.
Abdullah's, she had 21
steps. Or 21 steps.
21 steps
Yes.
in her theory.
Yes.
It frames our current nursing care plans, and that definitely has been carried over the decades. I definitely see how both of these nursing theorists, they're still part of our practice today.
Think about teamwork and collaboration.
That's so critical in nursing.
Multidisciplinary, yes.
Critical in nursing. Because sometimes we think the nurses think they can do everything by themselves. Some people really do. You know, they think, oh, I know everything. I can do it all by myself.
Yeah.
And that's not in nursing. Teamwork is very important. Yeah.
Collaboration.
Yes, when we talk to add to what you just said, to the teamwork and collaboration, we're also thinking about the patient, the family, and the community. That's it. Okay, the community in which we serve. So we have to collaborate with all these things, put everything together exactly in order, and then so it goes with what we're practicing today, like patient-centered care. Like Chris mentioned earlier, talked about then when doctors. It used to be physician-centered care. The physician will tell you what is good for you. I feel, Patricia, I feel this surgery is good for you. I need to give you this medication is good for you. Patients don't have to ask questions.
Doctor.
Exactly. But now we have to involve the patient with the care. We also involve other interdisciplinary, those in the health thing. We're talking about the dietitian, the physical therapist. The family have to get involved. Those with diabetes and other things.
Yeah.
Exactly.
So family effort.
Yeah.
What the QSEN is really pushing for, and the same as what the principles that these two theories came up with, is just making sure everyone is responsible. Responsibility is just very important. So in being responsible, we have to take in consideration all the 6 steps of the QSEN. We have to take into consideration the areas of patient-centered care. We have to take into consideration quality improvement, teamwork, collaboration, evidence-based practice, which is so very important now. And as FNPs, we should be thinking about taking this to the communities, because I'm sure we're not just going to be FNPs working in the hospital setting, but going in the grassroots where they really need us. Because if we're going to be talking to trying to get positive, right? Because if we're going to be getting positive outcomes, we have to go there. We have to start doing the teaching. We have to tell them based on what we have seen and the positive outcomes that we have gotten, in the past, or some research we have to use to back all of this. And then we've covered quality improvement too, and informatics, as we all said. And I think with the QSEN, the theories are still in there.
Even though it started in 2005, right? We didn't start here, It just came up rolling right now. People are now hearing all about this. This QSEN, they call the Institute of Medicine.
Yes.
And I think I like the idea.
Yeah, it's relevant, especially now that it's coming in the setting of education. It's empowering us, the persons going out now with a focus and a drive to say, let's go and make a difference. And we are here. We have multicultural sitting right here at the
right in
few of us. Maybe just few, but we are many. We are representing a whole nation. We are representing Africa. We are representing the Caribbean. We are representing the Caucasian. See, we're representing a whole lot of persons right here, so we can make the difference. And we encourage you watching us to make the difference. That's why we're going to be the great FNPs of tomorrow.
All right.
Thank you.
We're taking it to everywhere we're going, to the psychiatric nursing, to the home health care nursing, to everywhere.
We're taking it right there.
And then when you apply it, when you talk, most of us, some people might be in management during the decision-making process.
Yes.
You know, we
Yes.
have nurses sitting on the desk there. It's enough time we have other professionals making decisions.
That's
for us.
right.
Okay, with education and research, and then apply. You know, the QSEN, of course, is more about education. You know, in nursing.
Mhm.
We are the
Exactly.
future
We're the future. We
decision
can
makers.
yeah, exactly. We can give and we can join them to make decision making policies. People make policies and procedures, and then we carry it out. No, now we have to sit down there and get involved in that decision making process.
And then later on, we'll be hearing about Victor being our new theory.
I
Wouldn't
know.
that be
It's
nice?
gonna be Victor's theory.
So that brings up another good point. So we've been reflecting on these two nursing theorists from the 1950s and taking into consideration the evolution of our technology and advancements that we've made. Do you think that there's room for a new theory to be birthed out of this?
I think so.
Yes, I think.
So there's
I'll make one.
All right. I challenge you.
Yeah.
I think there's always room coming out of evidence based. Yes, and yes, evidence based because then they were saying on, do you know that different disease processes coming out now? Do you know that in taking all these selfies, there's selfitis? So
Oh
there's
my
theories coming
Lord.
out. Yes, and that's
Yes.
also one of them.
Yes.
But they have not yet found probably a drug for it. So probably could say.
There are a lot of things coming out. Evidence-based
Yes.
correcting a lot of issues that have
Yeah.
happened in the past. For example, don't
New
use
issues.
necessarily
New issues.
to loosen up secretions. It's not good anymore.
Yeah.
Don't use gloves outside. You have to use it, put it this way or that way. All those things. So you have to continue with evidence-based methods.
I think one of the ones that we need to push is education. Some feel that we're pushing education in the communities. It's important.
Preventative medicine, and that's a huge role for nurse practitioners to play.
Yes.
Yeah, that is where we
Preventative
come in.
medicine
Yeah,
and
primary
education
care.
in
Primary
primary
care,
care.
yeah. Because that's where
Gonna
our
be
focus
very
is. That's
big
why we
role
have to
for
teach to prevent, and prevent.
Thank you.
Well done.
Thank
Well,
you.
thank you for your time and joining us.
Bye. Thank you.
Watching us on the Few.
Watching the